Hello guys, I am Dr. Tayo Olusanro, and we will be talking about endodontics in the primary dentition today. Um, and my goal is to prepare you to diagnose, evaluate, treatment plan, and treat or refer endodontic issues of the primary dentition, including deep caries lesions, caries in mechanical pulp exposure, and pulpal conditions. Here are the corresponding textbooks in chapter 13 of the Child and Adolescent 10th edition by McDonald and Avery is really what you want to focus on if you have any of the textbook. Why pulpal therapy? The primary objective of pulp treatment of an affected tooth is to maintain the integrity and health of the oral tissues. So why do we do pulp therapy is because we want to keep that tooth. There is decay that is approximating the pulp or in communication with the pulp, and we want to keep that tooth for as long as possible. And it is the treatment objective to maintain the vitality of the pulp, if we can. But if the tooth is already non-vital, then there are other things that we can do which also fall under the umbrella pulp therapy. The major function of the pulp is the primary function is to provide vitality to the tooth, and other functions include induction of the surrounding tissues when the tooth is developing embryologically, and the pulp tissue will interact with the surrounding tissues and initiate tooth formation, not only embryologically, but also as the child is growing, for the accessional and successional teeth. The pulp will send inductive chemicals to that area at the periapical region to make the tooth bud grow. The odontoplasts in the outer layer of the pulp will also induce formation of the dentin that surrounds the pulp. The pulp will provide nutrition through the dentinal tubules to the dentin, and it's important for its formation and hydration. The pulp would also respond to heat, cold, pressure, operative procedures, caries, and the direct response is to stimulate the formation of reactive dentin or sclerotic dentin. This is to obliterate the dentinal tubules and pretty much protect the pulp. And the pulp reacts that way to help keep the vitality of the tooth. The pulp also provides sensation to the tooth via the nervous system, and it will transmit any sensation from the enamel or the dentin to the brain, which then interprets it as pain or pressure. So we have a patient that may or may not need pulp therapy. First thing is to get from an accurate diagnosis. We have to examine this patient, get a comprehensive medical history, dental history, and then you focus on the area and try to find out from the child or from the parent the subjective evaluation, like where is this hurting, how much does it hurt, how long does it last when it hurts, does anything make it hurt, and does anything prevent it from hurting, and does it come up by itself, does it disturb sleep. And then after you get that information, you then do your examination by looking extraorally first and then going intraoral. You may need some x-rays. You may need to perform other clinical tests like palpation, percussion, and check for mobility. So for your medical history, you really want to know if there's any underlying issues with this child. The important thing to note is we're going into the pulp, and in the pulp we have the neurovascular bundle. So besides the nerves, we have the blood vessels. So this is a way where you can introduce, if you're not careful, infection into the bloodstream. So you need to be really careful that this patient doesn't have any underlying medical history. If the patient is at risk for acute endocarditis or nephritis or cancer, or if they have some sort of neutropenic um, condition, you may want to extract that tooth, get rid of it, versus trying to do pulp treatment to preserve that tooth. So for the history of pain, you want to assess location, duration, frequency, and type of pain. Um, Type of pain could be, oh, it's dull and achy, or it's sharp. Frequency is it's there all the time, it comes and goes. Duration is, oh, once it hurts, it stays hurting for a little bit until I take some ibuprofen or acetaminophen. Location is important because some patients will tell you, oh, it's hurting on the bottom right. And then you look on the bottom right, everything looks really good. Nothing looks suspicious. It's always important to know that if there's something hurting on the right side, if you don't find it on the bottom, please look on the top. Referred pain can refer on the same side, top to bottom, but will never cross sides. Um, so if you have pain right after a meal, it may or may not mean that there is pulpal inflammation. It may just mean that there's food kind of stuck in a cavity, or food jamming against the gums, like food impaction. And a severe toothache at night is generally indicative of extensive degeneration of the pulp. Spontaneous toothache happening just on its own at any time indicates that the cavity has progressed, the decay has progressed into the pulp. There is some pulpal disease, and you may probably not get away with a pulpotomy. So when a patient comes to my office and I see a big cavity that looks like it's close to the nerve or in the nerve, what I generally ask is, does this pain disturb sleep? If they say yes, I let them know, because I don't do pulpectomies. I let them know I think it's time to take this tooth out. So, extraoral findings. You take a look at this patient, you check to see if there's any facial asymmetry. Do you see any obvious swellings? And then I want you to kind of palpate for the lymph nodes. Do you feel any lymphadenopathy, which means lymph nodes that are a little bit more pronounced, and it may be tender when you palpate. Other intraoral findings, like an abscess, like we can see in the picture, a draining fistula, check to see if there's any mobility, and do your percussion and palpation tests. Sometimes what I have noticed is, even if I don't palpate, I look in the periapical region of that tooth, say an upper first primary molar, you would see an area of inflammation. And then when you palpate in that area on the alveolar process, the patient may tell you, oh, I feel a little pain. Just pictures to let you know what it may look like. The picture on the left side of this patient, the swelling is encroaching close to the eye. It's most likely, when you see that, it's most likely an upper tooth that you are dealing with, most likely distal to the canine. It's really important when the swelling appears to be encroaching the eye that you do something really definitive. At this point, this tooth, I'm not going to recommend a pulpectomy. This tooth needs to come out and needs to come out as soon as possible. Sometimes with swelling like this, when you do your local anesthetic, because of the abscess, it would make the local anesthetic ineffective. So you may need to refer this patient to the hospital to get IV antibiotics, just to bring that swelling down. And then a few days after, you want to get the patient numb and get the tooth out. In this abscess, looks like it's the buccal space that is involved. It looks like it extends from just beneath the eye on the left side all the way to wrapping around the lower border of the mandible. Most times when you see swellings like this, it's more likely to be a lower tooth that is involved. And pretty much the same thing, because at this point, with this extent of swelling, I am very much concerned about Ludwig's angina. So I would really refer this patient to the hospital to get IV antibiotics, bring the swelling down a little bit before I go ahead and take that tooth out. If you're able to work in conjunction with the physicians at the hospital, once the patient has had some IV antibiotics, like a couple doses, it's okay to get in there and try to get the tooth out, if you're able to get some kind of sedation on board, because still with this kind of swelling, and it would take about 2 to 3 days for the swelling to begin to resolve, and with this kind of swelling, your local anesthetic most likely will still not work, but you want to get the offending tooth out as soon as possible. So in a situation where you are able to work with the hospital, have the patient get some antibiotics, a couple doses IV, get in there, sedate the patient, get the tooth out. When you're doing your radiographic examination, the things to look out for are, first, you want to look at your tooth, look at the cavity, make sure there's a cavity encroaching on the pulp. Check your periodontal ligament space. You'll also want to look out for very fine osteitis, which is pretty much periapical radiolucency. Sometimes if the infection has been there long-standing and there's like chronic inflammation, then you get condensing osteitis, which is pretty much radiopacity around the apices or the frication of the teeth. And where you would notice this pulp changes are in the periapical region and in the frication. You also want to look out for the root development. So if you have a tooth, say lower first primary tooth with a big cavity encroaching on the pulp, do I want to do a pulpotomy or do I want to take the tooth out? If the kid is about 9-10 years old, at that point, it's likely that your root development is a little bit more, your root resorption is a little bit more advanced because the tooth is about to fall out. So at that point, if it looks like you have some degree of root resorption, it's not a good idea to make the patient go through a pulpotomy, put a crown on it, if the tooth is going to fall out in about a year. In those kind of situations, I just take the tooth out and let the parent know, well, the tooth is going to come, the new one is going to come in very soon. You may opt to put in a space maintainer, just to kind of keep that space wide open. But usually at that age, if your 6-year molars are in good contact and your second primary molars are in good contact, you could get away without doing a space maintainer. Alrighty, so here is a radiograph, and I want you to pay attention to the lower right first primary molar. It has had a pulpotomy, but at the periapical region, you can see a little bit right here, if you can see where my mouse is pointing at. There is radiolucency right here, and when you see that, it just tells me that there is an ongoing pulpal inflammation and degeneration pretty much. the tooth is necrotic. I know we did a pulpotomy, but it looks like we were not successful. At this point, that tooth needs to come out. At this age, I will put in a space maintainer because we don't have our 6-year molars just yet, and I don't want this tooth to kind of tip over and eat up this space. So I'll put in a abandoned loop. On the left side, same tooth right here. If you compare it with the next tooth over, there is some degree of radiolucency here. There is very fine osteitis around the furcation of this tooth. The crown is not a very well-fitting crown anyways. So this tooth also looks like the pulp has failed. The pulp treatment has failed, and we would need to take this tooth out. Pretty much the same thing right here where my cursor is, you can see. And for this tooth on the top left, if you look right here, there is some degree of very fine osteitis, and look at the decay is so large. This tooth is not one that you would want to save. I think we could get away with a pulp treatment and a stainless steel crown on this tooth, but tooth number J, I think it needs to go bye-bye. So, pulp testing. It's controversial, especially in children, where your EPT in young teeth are very unreliable, and thermal testing is questionable as well because children are not very good historians. It's usually if a child presents with multiple large carious lesions, the parents may report that the child has never complained of pain. And children that are pre-verbal, meaning they're too young to tell or explain to their parents what's going on, or children that are nonverbal will even present a unique challenge because they cannot complain of pain. Some nonverbal patients that I've had the parents say he keeps smacking on his face or hitting his face against a wall or something hard, and then you look in the mouth and you realize, oh my goodness, there's a big cavity there, and he just cannot explain that he has that pain going on. For the pulp testing, because some kids will respond to discomfort as pain, their minds just cannot differentiate between discomfort and pain. When you pulp test teeth that are totally fine, they may tell you they feel pain on that one, on that tooth. So generally for me, I never use pulp testing in young children. I maybe start doing a pulp test at about age 10, 11, 12. Because at that point, I feel like they're mature enough to be able to differentiate between discomfort from the pulp test and actual pain. So for children, generally, I would do palpation. I rely on palpation and percussion. And while I'm doing that, I am constantly observing the body language, especially for children under 8, because they don't have the comprehension and verbal skills to recognize and express the difference between discomfort and outright pain. For example, if I have a tooth that I suspect that is hurting, I would first go to a tooth that we know is totally fine and healthy and just apply some pressure on it while I'm looking at the child's eyes. If the tooth is hurting, they will reflexively squint. So I know I kind of press on the tooth that I know is not. I apply apical pressure. Kind of like if it's a lower tooth, I have the tooth in between my index finger and my thumb would be at the border of the jaw, lower jaw, and I just kind of apply apical pressure in between both fingers, and I look at their eyes while I'm doing that. Usually, if they feel discomfort, they would squint. And if it's a child that squints at everything, when you press on a tooth that you know has nothing going on, they squint. You press on the tooth that's something certain, they squint. At that point, you may have to just rely on your x-ray or in your other visual clinical examination. So another thing that's important to evaluate is the level of patient and parent motivation to maintain adequate oral hygiene. You don't want to save a tooth that you know that is going to fail later on because the parents are not brushing. There's going to be decay again. So you want to do your caries risk assessment. And if it's a kid, if you're kind of like in between, should I save this tooth? Should I extract the tooth? If it's a kid with really poor oral hygiene, the parents are not motivated, caries risk assessment is high, I more likely tend towards extraction versus a pulp and on a crown. Also, for pulp treatments, things like pulpectomy, you want to evaluate the level of parent and patient cooperation. If it's not a kid that's going to be highly cooperative, it's not a good idea to do a pulpectomy. Also, if they're really defiant, if they can't, if they're like all over the place, freckles, rating scale 1, definitely negative, I most likely would not even do a pulpotomy. I just let the parents know, I don't think we can save the tooth. It's probably easier to extract this tooth. If we're going to the OR though, if we're gonna have the patient under general anesthesia, I of course will do a pulpotomy. So here is your AAPD caries risk assessment form, and it's important that you use this for every patient that you see in your practice. Also, there is a treatment protocol according to caries risk. So for a low risk patient or low risk probably won't have a lot of cavities. A patient that is moderate to high risk and the parents are engaged, you're more likely to take care of the cavities with do a pulp treatment with a crown versus a parent that is really not engaged. I most likely will try to extract the tooth instead. So treatment of deep caries lesions. The biggest indicator clinically is history of pain. Ask the parent, is this pain waking the child up at night? If the pain is just post-eating, like we talked about, it could be as a result of accumulation of food within the carious lesion, causing given pressure, or chemical irritation to a vital pulp, which is protected by only a thin layer of intact dentin. The options that we have for pulp therapy for a deep caries lesion is vital and non-vital. And under vital, we have the indirect pulp therapy, direct pulp caps, a pulpotomy. And the non-vital pulp therapies are the pulpectomy or the extraction. This is for primary teeth. Vital pulp therapy, so 90% of asymptomatic teeth with deep caries lesions, meaning this big cavity, very deep, approximated in the pulp and not in the pulp, can't be successfully treated without pulp exposure with indirect pulp therapy. And studies have shown that indirect pulp therapy is more successful than pulpotomy. So indirect pulp cap, it is for a vital pulp. The pulp should be normal or with reversible pulpitis. So if the patient says, oh, it only hurts when I eat something, you can do indirect pulp cap. If they say it's hurting by itself, it's waking me up from sleep, it's obviously not a candidate for indirect pulp cap. And you can use it for deep caries lesions, is asymptomatic primary or permanent teeth. Like we said, if the tooth is non-vital, or if you have radiographic evidence of condensing or very fine osteitis, if there's pulp exposure, if you have a symptomatic pulp, including thermal sensitivity, then you probably do not want to do indirect pulp cap. So when you do an indirect pulp cap, you want your restorative material to completely seal the involved dentin from the oral cavity, because the dentin has tubules. So if you have a poorly sealing restorative material, then there is a likelihood of the oral content seeping through, irritating that pulp, and that may cause your indirect pulp cap to fail. You want to preserve tooth vitality, you want to maintain asymptomatic status, and like we said, there should be no evidence of pathologic changes to the tooth or the periodontal bone. How do you complete an indirect pulp cap? Remove all decay from the walls of the preparation. Most important, your DEJ should be nice and clean. You want to leave a thin layer of carious dentin on the pulpal floor of the restoration. Difficult to evaluate or gauge how much is 0.5 mm. What I do is I try to remove as much decay as possible on the walls. DEJ, I pretty much leave the dentin on the pulpal floor. I place a thin layer of radiopaque liners such as an RMGI, like Vitribond or Limelight. You can also use calcium hydroxide. You can use zinc oxide eugenol or glass ionomer. Usually if you use something like calcium hydroxide, because it's very brittle and it kind of breaks apart and it can be porous and allow seepage of like fluids through it. Generally, I put like an RMGI over my calcium hydroxide if I do use it. And if you're using a zinc oxide eugenol, it's important to know that eugenol does not mix well with resins. It will prevent resin from setting, polymerizing properly. So if you are using zinc oxide eugenol, you want to place like a glass ionomer or an RMGI over it before you place your resin. And then you restore your tooth. So the picture kind of showing you the what we just talked about. Direct pulp caps. So it is indicated when you have a pinpoint mechanical exposure of vital pulp during cavity prep or after trauma. If it's decay into the pulp, you cannot do a direct pulp cap. The pulp needs to be normal. The pulp cannot be symptomatic, and like the one before with the indirect pulp cap, you cannot have radiographic evidence of condensing or rarefying osteitis. Pretty much the same thing with indirect pulp caps. The only changes is the only difference is you want pulpal healing with reparative dentin. Because we're in the pulp, we need the pulp cap medicament to stimulate the dentin to pretty much heal that area of pinpoint mechanical exposure. How do we do this? So following the pinpoint mechanical or traumatic exposure of pulp, so this can happen. You may need to do a direct pulp cap if you kind of get in the pulp while you're removing decay. You've removed all the decay, it's clean, and somehow you went a little too far with your handpiece, and oh my goodness, there's the pulp. Or the patient had trauma, fell, and oh my goodness, there's the pulp. What you want to do is place a biocompatible radiopaque material, such as MTA or calcium hydroxide. Recently, there's a new material, biodentine, which you can also use. So pretty much there's 3 things that you can place on the pulp: MTA, calcium hydroxide, or biodentine. Biodentine is a calcium trisilicate. You place your RMGI liner over it, like here for 20 seconds, and restore your tooth. Pulpotomies. A pulpotomy is the removal of carnal pulp in the tooth and preserving the vital radicular pulp tissue. And then you treat your radicular pulp tissue with a long-term, clinically successful medicament. Pulpotomies are used when there's a carious pulp exposure, or there's a large mechanical exposure, meaning it's not pinpoint, it's bigger than a pinpoint exposure, then you want to go ahead and do a pulpotomy. If you know there's inflammation limited to the coronal pulp, if there's absence of spontaneous pain, only pain in response to a stimulus that does not linger. So you can have reversible pulpitis. Once there's irreversible pulpitis, pulpotomy is not a good idea. Make sure there's no swelling, there's no abscess. If there's history of spontaneous pain, it's a no-go. If there's a fistula, necrotic pulp, if the pulp is hemorrhagic, so there are times when big decay close to the pulp or in the pulp, okay, we're gonna do a pulp therapy. This tooth does not wake up at night. There's no abscess, there's no pain on palpation or percussion. You get in there and you remove decay, remove the coronal pulp, and you cannot control bleeding. The pulp is just, gushing blood that is dark red. Most likely this tooth, the pulp is really inflamed, because if you cannot control bleeding after removal of your coronal pulp before placing your medicament, most likely this tooth should not be getting a pulpotomy. If you have periapical furcation radiolucency, or if you have pathologic resorption, then most likely you shouldn't be doing a pulpotomy. So what are the medicaments that we use for pulp treatment? Formocresol is the oldest medicament that we've used for these procedures, and there are conflicting reports that say formocresol is carcinogenic and it shouldn't be used, and there is studies that have shown that the amount of formocresol that we use in dentistry for pulpotomy is so little that it's not carcinogenic, and it doesn't even stay in the bloodstream long enough for it to cause problems. So there is, conflicting information out there, and some people still use formocresol because it's good, it works, and you've not had any reports of cancer as a result of using formocresol that is documented in the articles or papers. MTA is more successful than formocresol, but it's more expensive. So it's pretty much it's new, and the handling properties, not everyone is comfortable with using it. So I would, for me, MTA is gold standard, and if I could, I would use MTA for every pulp treatment that I do in my practice. Ferric sulfate, sodium hypochlorite, chlorhexidine, electrocautery, laser, and calcium hydroxide. The AAPD does not recommend calcium hydroxide to be used for pulpotomy, but some people use it, just so you know that the AAPD does not recommend it. Formocresol. Most commonly used material, high success rates, inexpensive, and what it does is it acts by fixing the tissue. It is bactericidal. It does not cause or stimulate dental bridging, but it may cause some calcific changes. It takes about 5 minutes to take effect. Local toxicity, there is, what it does is there is histologic reports, like when you look at it under the microscope, that it does cause some degree of chronic inflammation. Some people say it may cause succedaneous tooth damage, and it may increase the rate of exfoliation. That I have actually seen that some kids that have, it's not every child though, so some kids that have had pulp therapy with formocresol will lose that tooth faster than if they didn't. And it could be because of the formocresol, or it could be just because of the operative procedure. The tooth is just not happy because, it's not in its natural state anymore. Um, some tissue effects, foamcrystal on its own is highly toxic to cells, depresses fibroblastic respiration, um, blocks RNA and protein synthesis, and we already talked about the chronic inflammatory response, and may have mutagenic or carcinogenic potential, like we talked about. And the mechanism of action is it prevents tissue autolysis by reversibly binding to proteins. And it's important to know the different levels. I'm gonna just point out with my mouse here. You put your foamcrystal at the coronal orifice of the radicular pulp, and the first area is the zone of fixation, and the next area is a zone of diminished cellular activity. There is the zone of inflammation, and at the tip of the root right here is the vital tissue. So most of the pulp in the roots is have some changes as a result of the foamcrystal, and at the very tiny tips of the root is where you have vital tissue. So you remove the caries, get into the pulp chamber, and remove the coronal pulp tissue. You can either do your removal with a spoon excavator, a sharp spoon excavator, or a round burr on a slow handpiece. You put your cotton pellet on, dry cotton pellet first, with pressure to get hemostasis. Once you have hemostasis, you put your cotton pellet with 1 drop of foamcrystal, you squeeze super dry. You do not want that foamcrystal, you don't want the cotton pellet to be dripping wet with foamcrystal. It should be dry and just have the fumes of foamcrystal. You place it on the orifices of the root at the bottom of your pulp chamber, leave it for about 5 minutes, remove it, take a look. You should see the pinpoint stumps should have some, should kind of like turn a light to dark brown shade. You may want to then use like sterile water to clean your pulp chamber, and you fill with zinc oxyuronol and build it up with glass ionomer. I just put zinc oxyuronol all the way to the pulp chamber, and you put your stainless steel crown. For MTA is a biocompatible material, high success rate in primary and permanent teeth. It is alkaline, and it is at a pH of 10.2 when you place it. You mix the MTA powder with water, and when you do that, you get 10.2 pH, and it takes about 3 hours to set. At the time it is fully set, the pH changes from 10.2 to 12. The good thing about the MTA is it will form a dentinal bridge. So it will seal those orifices for you, versus the foamcrystal doesn't do that. The zinc oxyuronol doesn't do that. After caries excavation and coronal pulp removal, control your hemostasis with your dry cotton pellet. Place your MTA, lightly condensed with a moistened cotton pellet, and you place your zinc oxyuronol or glass ionomer on top of it. Because like I said, MTA is expensive, so you can't fill the entire chamber with MTA. You just put your MTA at the bottom, just covering the orifices a little bit into your chamber, and then you fill with zinc oxyuronol or glass ionomer. Then after that, you do your final restoration like a stainless steel crown. Ferric sulfate. It's a powerful and valuable hemostatic agent. And what it does, it eliminates the blood, and it controls bleeding without clotting. It is practically non-toxic. So for people that don't like foamcrystal, most of them use the ferric sulfate. And when used in pulpotomy, it is applied only for 15 seconds. Apply for 15 seconds, you rinse it off, and you do your zinc oxygenol in the chamber, you put your stainless steel crown on. It has lower clinical success rates. It tends to have some internal resorption um, as an untoward effect. And there was this report at some, I think it was a couple, about 4 or 5 years ago in the US. There were some patients that were getting sick after getting ferric sulfate pulpotomies, and this was because the heme in the ferric sulfate was feeding certain bacteria that were found to be growing in the water lines. And this bacteria, when you rinse off the tooth with the water from your air water syringe, if the bacteria had contaminated the water lines, once they hit the pulp with the ferric sulfate, they just begin to proliferate and get into the bloodstream. And a couple patients, well, not a couple, like a few patients were in the hospital because of this. Non-vital pulp therapy. Pulpectomy and extraction. So for pulpectomy, it's indicated in irreversible pulpitis. The tooth needs to be restorable, and you know that the pulp is probably not going to succeed with a pulpotomy. For example, you try to control bleeding, you're unable, hemorrhagic pulp. There's a lot of remaining, meaning the tooth is not about to exfoliate, and you have a cooperative patient. If the tooth is mobile, if there's a sinus tract, if there's interresorption, if there's pathologic external resorption, or the tooth is unrestorable, you do not want to do a pulpectomy. And what do? You eradicate radicular pulp remnants, pretty much you take out all of the pulp. You instrument the pulp mechanically, and you irrigate with sodium hypochlorite. And then you obturate with a resorbable cement, because this tooth is going to fall out, so you don't want something that is going to be non-resorbable. So, things like zinc oxygenol and calcium hydroxide is good for that. So what, there's just a picture showing what you want to do. Zinc oxygenol is the material of choice. However, it has some questionable biocompatibility. It is resorbable. Calcium hydroxide, very good biocompatibility. Questionable longevity in action, because it resorbs very quickly. So you can do a pulpectomy, and then 3 years later, take a picture, you find that your pulp chamber is empty, because the calcium hydroxide pretty much just resorbs really good, really quickly. It is bactericidal, because of some low-grade irritation, and it dissolves necrotic debris. So if you didn't do a really good job with your instrumentation, you put your calcium hydroxide in the chamber, or in the radicular, and in the pulp chamber, in the radicular portion, it will eat up whatever tissue is left behind. So it's a pretty good pulpectomy filling material. Pulp therapy in immature permanent teeth. So we'll just talk a little bit. We're all done with primary teeth. In young permanent teeth, if the tooth is vital, you want to do apexogenesis. If the tooth is non-vital, you want apexification. So apexogenesis is from the word genesis, something's growing. So you want to maintain the vitality of an immature permanent tooth with an exposed pulp. The tooth is alive. We want it to keep growing, so we do apexogenesis. Treatment should preserve pulp vitality to secure further root development and tooth maturation. There are two types: partial pulpotomy for carious exposure and partial pulpotomy for traumatic exposure, the Chevesque pulpotomy. Normal pulp tissue with minimal inflammation is present. Normal root end development occurs after you complete your pulpotomy. In immature teeth with pulp exposure, bacterial infection, or if a bacterial infection, long-term prognosis is related to the stage of root development and the amount of root dentin present at the time of insult. So the rationale for epexogenesis is if there is a poor long-term prognosis of because there is a poor term prognosis of endodontically treated immature teeth. So a tooth is still growing. You have wide open apices, what is called the blunderbuss apex. The root is short and the root is thin because the pulp is what stimulates the dentin to grow, like we talked about at the beginning of this lecture. If we cannot keep the pulp alive, this tooth will remain short and the dentin walls will be thin. So whatever treatment we're doing in epexogenesis is we're trying to keep this pulp alive so that the pulp can grow in length and in thickness. And the pulp of these teeth that you want epexogenesis on should have significant repair potential. So it shouldn't be a tooth that is necrotic. So if it's a caries exposure, when you're doing your partial pulpotomy, it should be a young, vital, permanent tooth with an incomplete apex, and you should be able to control bleeding within several minutes. If there is any degree of pulpitis, it should be reversible. If it's irreversible, you cannot do a partial pulpotomy. And the contraindications pretty much is like the opposite of the indications. How do we do this? You get into the tooth. Obviously, you remove the decay, and then you remove the inflamed pulp tissue beneath the exposure to about a depth of 1 to 3 mm or deeper until you pretty much reach the healthy pulp tissue. Irrigate to control the pulp bleeding. So you can use things like sodium hypochlorite or chlorhexidine, and you should be able to control the bleeding within 4 minutes. Once you can control the bleeding, you apply calcium hydroxide or MTA, about 1 to 3 mm layer of this, and then you seal with RMGI and restore the tooth. Shevek pulpotomy, the tooth is vital, traumatically exposed, young permanent tooth, incompletely formed apex. Pretty much the same thing. The difference, though, I know my presentation doesn't actually kind of differentiate, but the caries exposure, you want to do a coronal pulpotomy, so you pretty much remove all of the pulp in the coronal pulp in the pulp chamber for caries exposure. If you don't remove all of the coronal pulp, you need to expose the entire pulp though, and remove about 1 to 3 mm until you see healthy pulp. Healthy pulp would be bright red, like jello, and you should be able to stop bleeding within the 4 minutes. With your Shevek pulpotomy, where there's a traumatic exposure, usually you don't need to remove more tooth structure. You just remove a tiny bit more of the pulp, expose if it's a pinpoint, make it a little bigger, and go 1 to 3 mm, and then you try to control your bleeding afterwards. Apexification. This is when you're trying to induce root development and apical closure. Immature tooth, pulpless, meaning non-vital, necrotic pulp, open apex. Why do you want to do apexification instead of a conventional root canal treatment? The apex is open, so you can't really get an apical stop. Apex is wide open. There's no gutta percha cone that's big enough to kind of like fill that space. So you find it really hard to create an apical seal. Also, not only is the tooth wide open at the apex, the walls are still thin. Remember, we were talking about how the pulp stimulates the dentin to lay down. So the more the tooth is alive, the longer it is alive, the thicker would be the dentin walls. So if this tooth, before it reaches full apical closure, loses its vitality, the pulp can no longer stimulate the odontoblast to grow, the walls will be thin. Also, with that big wide open apex, it's hard to achieve dryness of your canal to obturate. So what we want to do is induce root enclosure to form a complete calcific barrier at the apex with no apparent pathology. Indications: non-vital teeth, immature permanent teeth. You don't want to apexify a tooth if the roots are really short, if there's marginal periodontal breakdown. If the tooth is vital, you want apexogenesis instead. How do you do this? It's important to know that any pulp treatment needs to be isolated with rubber dam. So all the treatments that we've talked about prior to this, all including this, will need to be isolated with a rubber dam. Never go into the pulp for pulpotomy, for pulpectomy, for apexification or apexogenesis without putting your rubber dam on. You want straight line access. You establish a working length, extirpate the pulp, irrigate with sodium hypochlorite or chlorhexidine for hemostasis, dry your canal as best as you can, and then you place calcium hydroxide or MTA just short of the apex, and then you seal the access with RMGI. What some people do these days is they use a collagen material like Colaplug or the things that you put in the socket after extraction. It needs to be collagen though, just to give you some degree of apical stop. Then you seal your access with RMGI. So you bring your patient back for recalls every 3 months to take a PA of the area, and you assess for root apex closure. After complete closure, you may extirpate your material just before the stop, and then you fill up with the gutta percha. So what you're going to have is you remove your calcium hydroxide or your MTA as best as you can. Once you feel the apex with your file that there is an apical stop, then you fill the rest of the canal and chamber with gutta percha. After that, you do your final restoration. There is a high incidence of root fractures in dentin after apexification because we don't have any pulp, so we cannot stimulate the dentinal walls to be thicker, so the walls are thin. And your restorative efforts should be directed to strengthening the immature root. Teeth that have had apexification should not be used as bridge or fixed prosthodontic abutments. And here are the references. These are the books that you may want to refer to. If there are any questions, please feel free to email. My email address will be on the packet that you got. And thank you very much for listening.